Up next we have Dr. John Barker. He's going to look at laparoscopic management. And Dr. Barker is currently a specialist obstetrician and gynecologist and has been a consultant in the UK since 2013. He is currently a consultant obstetrician and gynecologist at JRB Medical Center, that's number 10, 7th Avenue, Belleville, St. Michael. He has completed his postgraduate training in the UK via Mercy Deanery rotation, that's in Liverpool, and obtained his certification of completion of training. Ladies and gentlemen, please welcome Dr. Trump.
Hi, good afternoon. Thanks for inviting me to give a short talk. I'll try and make it as quick and simple as possible. You can't see too good.
You look at my mic.
Right, that's just a brief synopsis. My major interest is in gynecology, alternatives to hysterectomy, and I usually do outpatient hysteroscopy, which is essentially diagnostics in terms of putting the camera in your womb and then doing intraoperatively in the office. I do a little bit of endometriosis, colposcopy and minimal access surgery, and also two headless obstetrics. Hold on a second. No, I just touch it once. Alright, this is very trained in women's hospital. This is the largest standalone women's hospital in Europe. Comparatively to QEH, we do about 9,000 deliveries a year. It's tertiary, meaning that we do a lot of different specialties of obstetrics and Can you hear me now? Right. In terms of the talk I'm going to give, the guidelines or the evidence that we use, because we're practicing evidence-based medicine, will be the NICE guidelines, which is the National Institute for Clinical Excellence. Basically what it says is a different guidelines set up by this board. And what they do is actually give the guidance for gynecology and all the other specialties in medicine in the UK. So most of the evidence will be from them. It will also be from my college, which is the Royal College of Obstetricians and Gynecologists. And also too, it would be encompassing the guidelines of the European Society of Human Reproduction and Embryology. Now, endometriosis, we look at the picture on the left. Which one is for the left? Green one. Right, so that's your normal pelvis, yeah? So that is your uterus, that is your ovaries, that's the pouch of Douglas, and these two little things there, that's the uterosacral ligaments, and the bladder is usually at the front, yeah? So these are normal pelvis, pristine pelvis, yeah? If you see this, you smile because you don't have any pathology, alright? Now, this shows endometriosis there and there, yeah? This is the uterus again, ovaries, this is the pouch of Douglas, and this is the deposits on the uterosacral ligaments, yeah? Usually how this will present would be, if we examine you in the office, when we do an internal examination, what we call it biomanual, sometimes it can be tender when we actually examine you, and this would be the reason why most of the time if you have deposits on the uterosacral ligaments. This is just the powder burns, this is on the bladder. This is moderate endometriosis, so these are the adhesions to your bladder. That's the uterus, that's the ovaries and tubes. This is some scarring and inactive endometriosis as well. The whitest thing is the fibrosis. Now this is the, what we call the demon. This is the deep infiltrating endometriosis. This is the uterus here. This is the bowel, and as you can see, is attached from near the fundus, which is the top of the uterus, and it goes all around, all down into the pouch of Douglas. So it will go from here all the way down. Yeah. So these people have lots of pain. Sometimes it can be asymptomatic for all it takes, but usually you got deep dyspareunia, which is painful sex, and it's not superficial on the outside. It'll be deep dyspareunia. Now this is partial resection of the deep infiltrating, and this is the finished result here. So as you can see, the anatomy is more or less restored, and all the adhesions are broken down. Yeah. Now, in terms of surgical treatment for endometriosis pain, this is after we see you in the office, give you a trial of medication. We make the decision if to take you to theatre immediately, well not immediately, but within an elective time frame, within 6 weeks, or give you a short trial of medication. Now, to diagnose it is either by laparotomy or laparoscopy. They're both equally effective in diagnosing endometriosis. However, the advantage of laparoscopy make it the mainstream. So, and that is because you have a quicker recovery time. Yeah? And that's why we advocate laparoscopy. If, for argument's sake, the gynecologist doesn't have the necessary skills to do laparoscopic surgery, then the thing is for them to refer to somebody who actually does it. Yeah? Now, the grade A recommendation, in terms of evidence, what we say is that you have grade A, grade B, grade C recommendations. Grade A is the top recommendation. So when we actually do laparoscopy, if we find anything, it is mandatory that you treat it there and then. So you don't just go looking, see it, and then you come out and then see the patient in clinic in another few weeks and say, well, we found endometriosis, so we don't go back into treatment. Yeah? Because that was what it was 10, 15 years ago. Yeah? You come in, you have a look and see. So when we actually consent you in the office or hospital, we will say, well, if we see it, we treat it. Yeah? And this is the evidence behind it. Now, if we see it, we can do either one or two things. We can either ablate it, which is burning it, or electrocautery. So what we do is basically burn it with a current, or we can actually excise it. Now, both of them are thought to be equally effective. The only issue is that from the early studies, which were small, they leaned against ablation. Now, I live by two rules. Seeing is believing and tissue is the issue. So if you ask me, I'm going to excise it. When we excise it, then what we do is we can send it to the lab, and then the lab will tell us exactly what it is. And that's a confirmed histological diagnosis. Yeah? Now that's an example of the excision. So this is your normal peritoneum here, and this is the peritoneum after we have excised it. So this is when we remove all the endometriosis. Now the endometrioma is a cyst, and how that forms is that you get the endometriosis being deposited on the ovary, and then after a while you get built up, and then it buries into the ovary itself. Now when we scan you, this is the ultrasound probe here. This is the ovary. And how we diagnose the endometrioma is that it has what we call a ground glass appearance. So it's more like if you put like, like when you've, what's the best description of it? Like grounds after you drink tea and you shake it up, that's exactly how it looks. Yeah? Now this is it when you actually see it in the pelvis. This is the uterus here, this is the chocolate cyst, and that's in the pouch of Douglas. And this is exactly what it is here. Yeah, so this is the actual endometrioma here, and this is the ovarian tissue. Alright, so what we do is try to shell it out like if you have an orange, you know like how you peel the orange peel back, and then you have the actual orange. Well, the orange will be the cyst, and the actual ovary will be the orange peel. So that's essentially what you do. You just peel it out. Yeah. Sometimes it can be very easy. Sometimes it can be very difficult, depending on how big the cyst is. Now, for endometrioma associated pain, what we do is we perform what we call a cystectomy. Cystectomy is removing everything instead of drainage, because once you drain it, what happens is that you drain everything within the ovary, but then you don't take the cyst out. So what happens is that the cyst heals back, and then you get the recollection of the fluid. So actually, you're not doing the patient any favors. So that's why it comes back again. And basically, the guidance would be to do a cystectomy. Alright? Now this is another example of it. This is the ovary here, this is the endometrium here. What they do is just incise it, and then we just take it out. So what we have is the ovary, and that's the cavity there from where the actual endometrioma was. Yeah? And we usually do this for endometriomas greater than 3 centimeters. 2 centimeters would be too small. Now with the deep infiltrated endometriosis, like this here, this is what we try to dissect down. And the reason why it's complex surgery is because you got a lot of different structures, which would be like your ureters, which are the tubes from the kidney to your bladder. And sometimes these can get injured, sometimes you can have a bowel injury. So most gynecologists are not oncology trained, so that's why we have to have a multidisciplinary team in terms of colorectal surgeons, like Dr. Griffith. Now, these are MRI pictures. So this is your womb here, yeah, that's the bladder. This is your rectum here, and then you see a little dark thing right there. That's the deep infiltrated endometriosis into the intestine there, yeah. Likewise, this would be your bladder. This is your bladder here, and this is the womb, and that's a deposit inside the actual bladder. So like this here, you will get scars for this here, alright, so that will correspond to that. Whereas this will correspond to the ones before, whereby the front of the uterus, the womb, is actually attached onto the bladder. So in that case, we need a urologist to assist us in surgery. Now, in terms of the pain associated with the deep infiltrated endometriosis, surgery usually improves the pain and quality of life in women with deep endometriosis. Now, because it can be associated with complications, that's why it has to be multidisciplinary. Yeah, and what we would say was that in terms of doing the surgery, it definitely improves the quality of life. Yeah. Now, in terms of fertility, women with mild to moderate disease, what this suggests in terms of the guidelines would be to treat it. So if you have adhesions, if you have endometriomas or anything like that, you have to treat it. In terms of the technique, what we use is either the monopolar coagulation, which is essentially just burning. Yeah. Now, this is the same guidance as before in terms of fertility. If you have an endometrioma, what we do is remove the endometrioma, because if you don't remove it, it actually, your success rate for getting pregnant is actually decreased. But if you remove it, your pregnancy rates are actually increased. However, when we remove it, we must let you know that sometimes you can have a reduced ovarian function after removal of the endometrioma. It will be reduced, but not as much as if we actually left in the endometrioma. So it's like a catch-22. So we must tell you that it might be slightly decreased. And the same thing for the deep infiltrated. It will improve your fertility rates as long as we operate. Operative surgery increases your spontaneous pregnancy rates. If you use hormones, you can't get pregnant. So you have to operate to improve your fertility rates. After various treatments and stuff, if for argument's sake you're not responding to treatment, and one of the options is hysterectomy, what we suggest is hysterectomy with removal of the ovaries and all visible endometrial deposits. Yeah, can be done in women who have completed the family, or if after a while you got fed up and said, well, you're sure you don't want any children or anything, then you can do a hysterectomy. The only issue would be is that after you do a hysterectomy and remove your ovaries is your menopause. So that's why most gynecologists would be very hesitant to do a hysterectomy like in a 35-year-old woman, you understand? So that's where the issue will come. However, if we do it, it would be in the early 40s. Some might leave in your ovaries, but ideally take out everything. In terms of menopausal, you can put you on HRT, and the actual dose of the HRT will not be used to activate the endometriosis. Sacral nerve ablation. This isn't done much. It's very complex surgery. Dr. Waterman alluded to doing a caudal block in the actual lower part of your spine. This is actually cutting the nerve. But because it's very technical surgery and the risks are high, it's not. I've never seen one ever. Just that it is an option, but you have to be referred to the actual person who would do them, and they don't do more than 10 a year. Now the curved ball is, like Dr. Griffith said, if you go and you do a surgery and you see endometriosis and it's not significant, the question is, as a gynecologist, do we treat it or not? The guidance says no. If we go to do the tubal ligation, and if you find disease, if the patient is completely asymptomatic, they say that to leave it, because the primary indication for doing the surgery was not if you suspected endometriosis. You understand? Yeah? So that's the only thing. The GDC will be the guideline development group, and basically what it is the head honchos who actually makes these guidelines for us. But they found that if you actually saw it by chance, the thing is to leave it, because they don't actually know the true course of the disease. Now, in terms of hormone treatment prior to surgery, what they say is that you shouldn't be given hormone treatment prior to surgery to improve the outcome, because it does not bear any improvement on the outcome. If you had surgery, there are two types of hormone therapy that you can go on. The question is, if we give you medication, hormonal treatment after surgery is to prevent secondary occurrence of the disease rather than for pain, because it doesn't improve the pain, but it's more to stop secondary occurrence. In terms of hormone treatment, you can use the oral contraceptive pill or the Mirena coil, which is the levonorgestrel system. What this is the Mirena coil. Anybody knows what the Mirena coil is? No? Well, essentially it's like a cup of tea, but it contains a hormone that releases hormone in the actual womb itself. So it actually prevents the secondary prevention of endometriosis. So that lasts for 5 years. You don't actually have to be taking pills or taking other medication for 5 years. We just use that as a hormone, and then we can use like the non-steroids and stuff as well. This is basically the same thing, but what is telling you that we can use the hormone replacement therapy, or we can use a drug called Liviol, which is tibidolone. The interesting thing is that it was available in Barbados, and now it isn't. So I'm not exactly sure why. I'm not sure if it's cost or not, but it was widely available. But these are for women who actually had a hysterectomy and their ovaries removed. Now, in terms of other therapies, they don't recommend any use of nutritional supplements, complementary or alternative medicine, because of the potential risks and benefits are unclear, and that's because there's not much evidence behind them. But some people use them, but if you use them, I will tell you straight off, well, I don't know the evidence, so I can't condone it. Yeah, but it's up to you. There's no real risk of endometriosis and cancer, and what they found was that there is the risk of like non-Hodgkin's lymphoma the risk is increased with endometriosis, but there's no association in terms of it causes it. Yeah, but there's no increased risk of cancer. Now, this brings me to the important topic of placenta. Now, last year I went to a conference, and the glaring absence was that everybody had different stories to tell, and they had one common theme in terms of there was no group of people, or depending on the management, there was nothing that could be done for them. which I found a bit disturbing because overseas they have particular things that you can do in terms of the endometriosis center, and in terms of the actual surgery, most of the surgery from what the patients were saying were actually corrected. So they could have had a different outcome rather than the one that they had. So that's when I first mentioned it. Now there are numerous advantages. The first thing that is centralized care. When you have centralized care, it means that everybody is in one place or one locality, and everybody sings from the same hymn sheet in terms of protocols and stuff. And the reason being is we have the tertiary hospital, then we have multiple peripheries. So what that means is that you can get different protocol in one hospital versus another hospital. So you can get varying levels of care, but the problem with that is that everybody that is complex then has to be referred to the tertiary. And tertiary is the main place that we get centralized care because they actually see the worst cases, so they're the best people to actually do it. Now, when you centralize, you have a multidisciplinary team. Now the multidisciplinary team will consist of a myriad of professionals, which would be your neurologists, your anesthetists, colorectal surgeons, your adolescent pediatric gynecologists, urologists as well. And depending on if you have any extra genital site for the endometriosis, like your lungs, you may have to bring in the cardiothoracic surgeons and stuff. Yeah? So there are clear protocols of management, and overall what it does is improves the level and standard of care. And in terms for the clinical governance and stuff, what we try to improve is the level and standard of care. And what this is like a risk management program, so we actually try to improve the standards every year. It's basically I would say a peer review system whereby you look over the protocols. Sometimes it can be very hard on yourself, but the main effect is to actually improve the standard of care. Now, in terms of the multidisciplinary team, usually consists of a lead gynecologist and gynecologist with a special interest, colorectal surgeon, so pain specialist, psychologist, urologist, and most essentially you need a radiologist with an interest in endometriosis. And the problem is, because Barbados is a small place, everybody is mottled down. So everybody has to be a jack of all trades. So depending, compared to overseas whereby you have a lot of radiologists, so one might be a general radiologist with an interest in gynae pathology, one might be interested in bowel and stuff. So that's how you get the improvement in service because you have different special interests. And also too, you have to have access to fertility services because most of the people with endometriosis are actually young and want a family. Now, in terms of the referral process, usually it could be done by the general practitioner. If endometriosis is suspected or previously diagnosed, you can be referred from the gynecology clinics if you have suspected or diagnosed after laparoscopy. The way how it is, you can educate the patients so the patients know that this is a center in relation to what is being offered, because in terms of education, some patients might not even know it exists. Some people might just suffer in silence. So that's why you have to put it out there that this is a center, this is what we do. But then there are powers that would prevent you from doing that as well too. So that's the only issue with that. And basically, women can be referred if they're suspected to have confirmed or suspected deep endometriosis involving the bowel, bladder, or ureter. Now, women or adolescents aged 17 or under with suspected or confirmed endometriosis, they must be referred to the adolescent and pediatric gynecology service, whereby they have specialist attention. Now, in terms of the multidisciplinary team, what they do is review the cases. So if somebody comes in another week or two, they will go through the cases, see exactly how complex the case is, and then what they will do is then plan the optimum management And the management would depend on the type of complications and the potential complications that might happen. And this will be, you will have a good idea when you do the MRI scan, because you know exactly how bad the endometriosis is. And the other thing is that before to plan the surgery, sometimes they might have a second look laparoscopy. So you have the initial surgery, and then you have a second surgery, and then the third surgery they actually do what they're supposed to do. Now, the clinics, we have routine clinics, usually weekly, whereby new patients will have a history examination. The mainstay is laparoscopy and diagnosis, because in this thing, remember that most people take 10 years before they're actually being diagnosed with endometriosis, so laparoscopy is the mainstay. If it is mild, then you see and treat. If severe, immediately send them for MRI and review in the NDT, and then you have your secondary surgery. In conclusion, from what I see, an endometriosis center is needed. This is to streamline the care, both from presentation all the way through, evidence-based care, because everything is evidence-based now. So I want to actually do something unless there's evidence behind it, because that's how we're supposed to do it. But you have to have patient-centered care as well too, meaning that the patient is in the middle. You have to listen to them. Sometimes with the endometriosis patients, I find that they get very frustrated, but it's understandable because sometimes they think that we don't understand what they're actually going through. So sometimes they get frustrated, we get frustrated as well. Especially if you have like people that have been in the hospital a lot of the time. And the problem is that when you examine patients, some of them, when you examine the abdomen, it's completely non-tender. And when we as doctors examine a female, what we look for is tenderness on the tummy. We look for tenderness when we examine inside. And usually when we examine endometriosis patients, they will be telling you that they're in pain, but when we examine you, we can't find anything. Alright, so that's where the variance comes. So sometimes you'll see like in care especially, you just admit you're looking for pain relief. Usually within 24, 48 hours, they will go home. And that's how you get most attention between doctors and patients as well. Any questions?
Mark, do you see us establishing such a center, if you had to put a timeline on it, and given the resources and current situations, do you see us having that within the next 10 years, if I had a special program?
You can do it all no. We got the expertise.
And the resources.
And the resources, yeah. Any questions?